Hello, I would like to thank the organizers for inviting me to discuss this fun topic. What should we do in the presence of cerebral microbleeds if such patient needs antithrombotic therapy? These are my disclosures here. My research support comes mainly from National Institute of Health, but I also got some research funding from industry as well. I'm glad that this session is happening because even our close colleagues in cardiology are realizing that patients at high bleeding risk represent up to 40% of subjects undergoing percutaneous coronary intervention in routine clinical practice. And this particular patient population has been left out of the randomized controlled trials, trials for devices or drug therapies. So the paucity of randomized clinical evidence causes problems in their management. I am indeed facing Dr. David Waring. David is a close friend, and he came up with probably more than 50% of quality evidence supporting the view that microbleeds are dangerous when it comes to antithrombotic and in particular anticoagulant treatments. But I'm not going to fight him on one thing. So the use of antiplatelets, single antiplatelet in patients with microbleeds, that is fine. In this study where David also participated to with his team, the restart study, they enrolled adult patients 18 years old or older who were taking antithrombotic, either antiplatelet or anticoagulant for prevention of occlusive vascular disease. When they developed intracerebral hemorrhage, these patients had discontinued antithrombotic therapy and survived for 24 hours. So in this tricky patient population, they randomized these patients to either start or avoid antiplatelet therapy. Just antiplatelet, not anticoagulant. The results are here. The primary outcome measure was indeed recurrent intracerebral hemorrhage, and the rate of recurrent intracerebral hemorrhage was 9%. 9% in the non-antiplatelet group or avoid antiplatelet therapy group. It was only 4% in people who were restarted on antiplatelets. So antiplatelets do not pose a big risk even after an intracerebral hemorrhage. The other thing to remember here is that yes, there was almost a positive difference in using antiplatelet after intracerebral hemorrhage in this patient population. But using antiplatelets did not really make much difference, any difference actually, in terms of preventing all major occlusive vascular events. You see the p-value, which is 0.97, and the hazard ratio is literally 1. So yes, they didn't cause much harm, but at least in this particular patient population, they didn't help much either. Microbleeds are not the only MRI visible lesions. Superficial siderosis is also another important marker of brain bleeding. So even in someone who needs antiplatelets, if you see widespread superficial siderosis like you see here, the risk of brain bleeding might be high. If such a patient has low ischemic risk, such as stable coronary artery disease, no stents at all and such, one might consider withholding even antiplatelet therapy in such a patient who has microbleeds plus superficial siderosis. And this study showed that presence of superficial siderosis is a significant risk factor for first-time intracerebral hemorrhage, even in patients without past history of intracerebral hemorrhage. The problem is mainly about anticoagulation. And part of the problem emanates from the fact that no warfarin or non-vitamin K antagonist oral anticoagulant randomized controlled trial ever included any patient with past history of intracerebral hemorrhage, and patients with non-high ICH risk were also excluded. These are the key questions in patients with microbleeds and an indication for anticoagulation. What is the indication? What is the required duration of full dose of anticoagulation? And is there any alternative to lifelong or anticoagulation in general in such a patient. In order to better understand these questions, let's review these preliminary questions first. So why do we care about intracerebral hemorrhage risk when anticoagulant use is needed? Two main reasons. Oral anticoagulants, including NOACs, increase ICH risk, and outcomes of oral anticoagulant-related ICH, including NOAC-related ICH, are extremely poor. This network meta-analysis clearly shows that, totally based on randomized controlled trials, Coumadin increases intracranial hemorrhage risk by about 5-folds, and even the better behaved direct oral anticoagulants or NOACs, they increase the intracranial hemorrhage risk by 2 to 3-folds in currently prescribed doses. What happens when we compare direct oral anticoagulants to antiplatelets? This study compared rivaroxaban to aspirin in patients who sustained an embolic stroke of unknown source. And as you can see, patients randomized to rivaroxaban had almost 7 times higher risk of developing a hemorrhagic stroke than compared to the aspirin group. There is some confusion about apixaban and aspirin in Averro's study that enrolled patients who had non-valvular atrial fibrillation deemed by their physicians to have problems with long-term warfarin treatment. They were randomized to apixaban or aspirin. And in the intent to treat analysis, there was no difference in major bleeding events between apixaban and aspirin. But when we look at complications, what matters is really the on-treatment analysis. And this, in the same New England Journal of Medicine paper, when the authors looked at the on-treatment analysis, they saw that apixaban was associated with a 1.4% major bleeding rate versus 0.9% major bleeding rate in the aspirin group. So indeed, apixaban is associated with higher rate of major hemorrhages. What happens when intracerebral hemorrhage develops while using a direct oral anticoagulant? Again, the unbiased or least biased results would come from randomized controlled trials. When we look at Rakutaev and Aristotle, the drugs that are most commonly used in clinical practice nowadays, if a patient developed an intracerebral hemorrhage while on warfarin in Rakutaev, immediate mortality was 50%. If such intracerebral hemorrhage developed while using rivaroxaban, immediate mortality was 48%. For apixaban, this rate was 45.4% in Aristotle and 42.6% for warfarin, again in Aristotle. So we are talking about 45% to 50% immediate mortality when a hemorrhage occurs while using a direct oral anticoagulant. So next question is, what's microbleeds got to do with ICH risk? I will tell you upfront that microbleeds increase intracerebral hemorrhage risk in every patient population, and this risk is compounded when anticoagulants are used. So it might make sense to first take a look at the rate of incidence of intracerebral hemorrhage in the general population. In people over 55 to 65 years of age, annual risk of intracerebral hemorrhage is about 0.1%. So in patients who have CAA-related intracerebral hemorrhage with strictly cortical microbleeds, the annual recurrence rate is about 10%, like 100 times in general population. If a patient had a strictly deep hypertensive, deep intracerebral hemorrhage plus minus deep microbleeds, the recurrence rate is 1.6% per year. And if a patient had either a lobar intracerebral hemorrhage and a deep microbleed, or a deep intracerebral hemorrhage and one or more lobar microbleeds, the annual rate of recurrence is about 5%, which is, again, 50 times higher than the rate in the general population. So microbleeds are important in people who sustain the intracerebral hemorrhage. This study looked at the rate of first-time intracerebral hemorrhage in people who never had any brain bleed before, but who were found to have incidentally cortical microbleeds on brain MRI. And the risk of first-time intracerebral hemorrhage was 5% per year in this population. And anticoagulant use and older age were independent predictors of future intraparenchymal hemorrhage in these lobar microbleed-only patients after correction for other covariates. This study from Korea also clearly shows that when you compare people who had warfarin-related intracerebral hemorrhages to people who use warfarin but never had intracerebral hemorrhage, the ones who had intracerebral hemorrhage on warfarin are a lot more likely to have microbleeds in their brains. So the difference was 80% versus 23%, huge difference. And in the multivariate analysis, presence of microbleeds and also white blood hyperintensities were significant predictors of intracerebral hemorrhage. This one actually comes from Dr. David Vering's important meta-analysis in over 5,000 patients from 15 studies who had a ischemic stroke or TIA who received brain MRIs and follow-up. 25% of them had brain microbleeds, and people who had microbleeds were 6 times at higher risk of developing intracerebral hemorrhage than compared to the ones who did not have microbleeds. A much higher rate than you compare it to pooled risk of recurrent ischemic stroke. So we are talking about 6 times higher risk of intracerebral hemorrhage in in patients who had microbleeds after an ischemic stroke on brain MRI. And the more microbleeds one had, the higher that risk was. Another study that enrolled more than 1,500 patients from 8 centers. These are people who had brain microbleeds, who were anticoagulated, and in this population, 30% of them had brain microbleeds. And again, the intracranial hemorrhage risk was much higher in this patient population with atrial fibrillation. So when you had microbleeds and atrial fibrillation, you are a lot more likely to have intracerebral hemorrhage when you use anticoagulation. This is the excellent prospective study that Dr. David Vering led, and they enrolled, again, about 1,500 patients prospectively to this observational study. These are patients who had an ischemic stroke or TIA, and who were started on anticoagulation. If the patients with the microbleeds on baseline MRI were almost 4 times more likely to have a intracerebral hemorrhage in follow-up. And you see how the Kaplan-Meier curves become even more different after only about 20 months of follow-up. So the longer they go, the higher the difference will be. And David's findings were totally reproduced in this study from Spain that was again published in Green Neurology just last year. And again, people who needed oral anticoagulation after an ischemic stroke, 22.5% of them had microbleeds on brain MRI, and the ones who had microbleeds were 3 times more likely to have an intracerebral hemorrhage. And these are data from Rotterdam scan study, and in this very healthy older adults, presence of any microbleed on a research MRI was associated with 5 to 6 times higher risk of developing intracerebral hemorrhage. So even if you have no other pathology, no other condition, presence of microbleeds is a huge marker for intracerebral hemorrhage risk. So a 73-year-old person, CHA2DS2-VASCOV7, multiple risk factors with non-valvular atrial fibrillation, comes in with a TIA in 1997, no stroke, no microbleed, is kept on warfarin. 6 years later, come back with another transient neurological deficit, and this time 1 microbleed is found, is still kept on warfarin, and 7 years after that, and 13 years after the initial event, the patient comes back with a fatal intracerebral hemorrhage, while the INR was only 2. So factors to take into account when anticoagulation is needed: stratification of ischemic and intracerebral hemorrhage risks we discussed, indication for anticoagulation, duration of anticoagulation, presence of FDA-approved alternatives. The most critical issue is non-valvular atrial fibrillation because it requires people to be on lifelong anticoagulation. And in this patient population, now we have an alternative to lifelong anticoagulation, which is left atrial appendage closure. The PROC-17 study that was recently published clearly showed that left atrial appendage closure, endovascular left atrial appendage closure, is equivalent to direct oral anticoagulant use in terms of preventing all strokes and for ischemic strokes as well. The two approaches were similar. This is the summary slide, and these are key questions. So I don't say no to short-term anticoagulation in patients with microbleeds if there is no alternative. So up to 3 months for post-MI stent or post-left atrial appendage closure. Intermediate duration, such as what we need after a DVT or when intracardiac thrombus is found, is also in general acceptable in most patients. The problem is mostly for lifelong oral anticoagulant use. There are situations where we have no alternatives, such as hypercoagulable state related to antiphospholipid antibody syndrome. Tough alternative, you wouldn't replace a mechanical valve with a bioprosthetic valve in people with microbleeds. But whenever there is a good alternative, such as patients with non-valvular atrial fibrillation with brain microbleeds, left atrial appendage closure should be considered then. And in summary, cerebral microbleeds increase ICH risk in every patient population. The risk is compounded when anticoagulants are used. Outcomes of anticoagulant-related ICH are very poor. And if a patient has an indication for anticoagulant use in the presence of microbleeds, okay to use anticoagulants for a short course in most patients. If long-term course is indicated, must use it if no alternative. But if there is an alternative, such as left atrial appendage closure for non-valvular atrial fibrillation, then consider that alternative. And this is my final slide. In 1980s, Nancy Reagan was saying no to drugs. I agree with that. And in 2000s, Nancy Reagan is saying yes to novel therapies, specifically stem cell therapies. And I totally agree with that too. And please say yes when you vote for that particular discussion. Thank you.